Giving the keynote speech for the research and development session here at WHSS. Yesterday, we heard a lot of great discussion and a lot of great speakers, and research certainly came up as a topic of import across many of the conversations that we're having. So again, it's my honor to be here to talk about this with you all, and I agree, I'm looking forward to your questions and an interactive session. So I'm here just to lay the groundwork for the next hour that we have together, and what I thought I would do is just talk about research and how I see research throughout my career and what it can do to promote us getting towards the SDG goals. What is research? It's defined in many different ways, but I think the important aspect of research is that it forces us to look at what we're doing, to know that what we're doing is what we intend to do, that we're not causing harm, and that when we're implementing interventions, that we're implementing the right interventions and not wasting appropriate resources. Research is also important, and we did hear this yesterday as well, in terms of advocacy and laying the groundwork to accept new innovations like technology, and also to establish policy. And it's important for policy to be based in evidence so we know that we're implementing solutions that work. And as far as research goes, it's also beneficial for everyone. A well-conducted research study will go beyond the borders of the institution or institutions that the research was conducted in. And for example, in the United States, where we have a very high healthcare cost and outcomes that don't necessarily match that level of import, we are actually looking outside of the United States for some best practice solutions. So some of the solutions that have been implemented in low and middle-income countries actually is being applied in the United States when we look at things like getting healthcare workers into patients' homes to provide the care instead of having patients always come to the doctor's office and hospitals. So we see that as an intervention that has been effective, but also cost-effective. So that's important. So research is without boundaries in terms of how it can be applied. And research can be conducted in many ways. We have bench research, and one of my colleagues up here was a researcher on the bench. And then we have applied research where we're looking at taking those lessons from the bench and bringing it to the bedside. And research comes from academic institutions, and it also comes directly from the clinicians in the practice space. And that's where I personally got my experience, was as a pharmacy student. During my research training, we identified that we weren't appropriately dosing the aminoglycoside antibiotics. So the first initiative was, let's put a program into place to improve the dosing, but then we needed to do some research to make sure that we were achieving the endpoint that we desired and that we weren't causing any additional issues for our patients. Now, of course, that's not to say that research comes without barriers. Of course it does. And these barriers can be at both an individual level, but also at the systems or the organizational level. So researchers themselves may not see themselves as research, but as Dr. Olu said yesterday, we can all do research. We're all researchers as healthcare clinicians. And students, you are well poised being early in your career to get started on this path early on. But barriers come in the barrier of time. Everybody feels burdens of very high workloads, I'm sure. Also the resources for the tools to apply the research, as well as the education on how to perform research. This is an important component of doing this. Also, when we talk about research, we also need to think about interpreting research and applying the results. So some folks may not have the confidence to critically evaluate medical literature, but that is a skill that we should all also think to acquire, because it's one thing to do research, and then it's another thing to read it and apply the results. So I just want to put us on a positive note to get started on the panel. Across the world, the public interest in research is growing. UNESCO recently put out a report and showed that the investment in research in low and middle income countries is actually representing a larger portion of total research spend. So between 2007 and 2013, low and middle income countries actually represented 20 up to 30% of total research spend. And finally, when we look at authors of publications over that same time period, publications with African authors increased by 60%, and publications with authors from Arab states increased by 110%. So there really is some positive forward motion going, and a conference like this that brings students together to talk about research and development early on in their careers is another really positive movement. So with that, I think we'll get started with the panel.
Okay, thank you, Dr. Greenwood. Of course, we've seen that health research is important in improving care and treatment, and it does not only do that, but it also influences the policymakers to take decisions. So, and in that, so it also guides us in the development goal, the Sustainable Development Goals, the SDGs, which we are actually looking at SDG 3. So without going further, Professor Kayumba, this is addressing to you. So how is research impacting the healthcare development in terms of medical research on human health and longevity?
Thank you very much. As Dr. Greenwood said, conducting research is something, but implementing is something else. So we all, as academic institutions, conduct research in health system, clinical research. But then for which purpose? The purpose should be the well-being of the population. But in the past, research we were conducting were either aiming at publishing. I publish, I get my PhD degrees. As an associate professor, I have been publishing. That's why I have been promoted. And so what? Did my research impact on the population I'm serving? Now currently, you guys have chosen really a nice topic. The current research in this area should focus on impacting on well-being of the population. Any research that is not focusing on well-being of the population shouldn't take place, because this is our goal. Long time ago, research and development happened at different levels, like developing drugs we are using, making sure they are developed and they are efficient and safe. You know, different clinical trials those medicines should pass through in order to get to the market. You know, even in the market, they should undergo what we call pharmacovigilance phase, where you are sure that they are still safe. And still, research continues either to improve pharmacokinetics part of those drugs, make them efficient as fast as you can, make them less harmful, etc. So all those activities aiming at improving either process or new products or improving existing products are known as research and development. So as a future professionals, once you are asked or once you apply for research and development in an institution, be aware that your primary job would be to improve the process or to improve existing products or to create new process that will help your institution to meet the client expectations. And for the moment, since we are in healthcare system, the aim at improving the well-being of your client, which is the patient. I want to highlight some challenges, especially when it comes to academic institutions conducting research and some industries involved in healthcare system. I will talk about pharmaceuticals since I'm coming from pharmacy. Currently, there is a lot of products under development. Obviously, they will need to be tested for safety and efficacy, and that where come in academic institutions. And that kind of partnership is very key. Then, being academic institutions linking with industries, the competition is very high. Therefore, capacitating people to write grants and win grants is a challenge we face. So we should be able to compete, show ourselves as really the most appropriate institutions to help those industries to improve existing products or to create new products. And we hope that through this symposium, we will go back with really a goal of improving the way research is being conducted, orienting research in the way it impacts the well-being of the population, and eventually review our capacity in competing and winning such partnership with pharmaceutical industries. I think I can stop there. If I get another opportunity, I will talk specifically to pharmaceutical products, especially vaccines. Thank you.
Yes, thank you very much. Still on that, Dr. Mazzarati, when we talk of health research and the public interventions, so Professor Kayumba has in the beginning said we do research. At one point, all of us here have conducted the research, but then what? So how is the research, the health research that we are doing helps us in the public interventions in trying to improve the health care of our populations?
Thank you. First of all, I want to excuse my Director General, Professor Chondo, who couldn't be here. And I'm so happy to be a spare wheel. So you won't get much from me, but as a spare wheel, even in the booth, you know that it is very important whenever there is, you have to spare. Research and public health interventions. In Africa, we have one challenge. It is about data. The way we collect data, their accuracy, so that we can make evidence-based decisions. There are so many research which go on in Rwanda, in Africa, and around the world. But those research might be blind whenever they don't target anything of interest to the population or to our nations. I want to give you two examples of Rwanda research and public interventions. One, in my area. We have in Rwanda 2 principles to articulate our way to deliver care. One is the geographical accessibility. We want every single Rwandan to access health care. Then about geography, how do we go around the hills? Build hospital infrastructures. We have 7 referral hospitals, 4 provincial hospitals, 37 district hospitals, over 500 health centers. We're building over 1,000 health posts, and we have an army of community health workers, 45,000. All those to make sure that whenever a Rwandese needs care, can access it in terms of geography. The second principle, we want our healthcare to be affordable. Then we talk about mutuelle de santé, health insurances. So when I see geography, by now, a Rwandan walks 51.2 minutes to access by foot a health center, which is very important in terms of accessibility. So when you see in public health improving, it is not just around improvement. It is around thinking through data, around thinking through works, around thinking through the pain the population is going through so that we can make a decision which is ground-based. That's very important. So I would like you students who are gathering here from all over the world, 32 countries I heard, I would like to make sure that what we do in academics, if it is not translated into something of interest to our nations, then you are just doing what Aristotle said, the joy of knowing. But the joy of knowing, without the joy of doing, there is no rejoicing. So if you want to combine both, the joy and the rejoicing, you have to make sure that what we have in our brain, in our heart, is translated into acts and actions. And I hope that your questions will further nourish what we are going to be doing here as a debate. Thank you.
Yeah, I couldn't agree more on the conversation that has been shared. I mean, I look back on what I did my PhD on. It was exciting science, but has no application. Many publications, but had no applications. And I look back, you know, I had many awards, but looking back, I'm asking myself, that was interesting, but it wasn't applicable. Now, looking back in my career, you know, I have been a chief scientist of a company that Johnson & Johnson acquired. That's how I became Johnson & Johnson, and as many of you probably read my bio, I've been blessed with many inventions. But what really struck me is, what is the goal of life? Even my life is the patient is our North Star. The patient should be the core of what we're focusing our research on. At the end of the day, if our research has to improve the quality of care, but also it cannot be expensive, it has to be low cost, so that it can be easily accessible. When we look at Johnson & Johnson's credo, the first is patience. And when I always think about that, I always look at, you know, understanding the root cause. How can I deliver the best solution to look at the prevention, look at intervention, as opposed to putting all my efforts around cure? There's nothing wrong on the cure, but if we can do research to give us insight in how to prevent and how to intercede in the disease progression, we have significant impact to really change the course of the healthcare. Now, You know, there are certain areas that I have also focused on artificial intelligence, machine learning, and how to make robotic surgery. You know, I'll call it democratize it. We know in the US, the cost of robotic, robots are exceptionally high, and they're only accessible in big hospitals. The question is that if we can implement machine learning, artificial intelligence, where even we can bring the cost of robots down and being able to really understand the robot sensing the presence of nerves and avoid unintended damage to nerves, that really will end up decreasing the cost of surgical outcomes. What I also think about interventions, in terms of research, is really thinking about smart devices and incorporating those in our daily lives, and how that information that we gather from smart devices can help us to intervene. I always think about some of the work that I've done in the translating technology into improving clinical outcomes. For example, in the area that we're looking at is in 3D printing, for example, fundamental research has been done, but applying the knowledge of the 3D printing into surgical repair. Right now, someone has a major traumatic leg injury. The likelihood that it's going to be amputated is very high. But if we can 3D print a bioabsorbable polymer as a scaffold, we take the CT scan, translate that CT scan to an STL file, and then the STL file converted into a 3D printed cage of a patient to implant that. So we're learning, we're taking fundamental research, but translating it to improve clinical outcomes. That should be our focus. And I believe we in Africa can do the same thing that's being done in the developed world. Instead of putting our efforts on all our efforts, there's nothing wrong with basic research. We need to do those things. But at the end of the day is converting those basic research into translational research, and with a focus on developing really transformative solutions, but bringing the cost down and improving the clinical outcomes. That should be our focus as we're focusing on doing interdisciplinary research in our institutions. Thank you.
Thank you very much. Still on the focus, Dr. Mazzarati, I'm just going to quote you, just mentioned that joy of knowing. Joy of knowing. We've collected data and now we have data, so we know the data. And so coming back to Dr. Boni, how do you use the data that we have in relation to quality improvement in healthcare delivery? How do you use this data to try to improve patient care?
Thank you. So in regards to this question, I think part of it is setting goals and measures. And so even when we look at the SDGs, you have the goal, and then you have the target indicators that will tell you that you are on your way to achieving that goal or not. So it's important to set goals and then use that data to know, again, whether or not you're on the way to getting there. In my experience, quality improvement research is hugely valuable because we may think that we're implementing an intervention that will have a positive outcome or that we're implementing it appropriately. But without systematically evaluating what that implementation effort does, we may not actually be having the impact that we're looking to have. One example that stands out to me is the WHO Surgical Safety Checklist. And that was developed and showed incredibly wonderful outcomes in regards to mortality reduction after surgery. And institutions that implemented it saw good outcomes, but over time, it came to attention that maybe everybody wasn't consistently implementing it in the same way or completely, and perhaps that the outcomes being achieved were not as good as they could be, or potentially they could actually be causing worse outcomes because a checklist may give you a sense of complacency that, oh, if I check a box, I'm doing a good thing, but maybe I've skipped some steps. So research was undertaken to evaluate over several different institutions how that checklist was being implemented. And they actually found that the checklist was not being completely implemented across many centers and looked to identify what components of the checklist were more or less likely to result in poor outcomes. So to me, what that says is even though we might have had a great research study that shows us an intervention that worked, we can bring it into our own institutions and it may not be working to its full impact if we're not applying those interventions correctly. So that is, I think, very important, and that's why you need the data to be able to assess that you are indeed achieving those targets, whatever those targets may be.
Thank you very much. I'm now going to take a set of questions. I'm going to only take 3 questions from the audience. Just 1 question, and please mention who you're addressing the question to. Of course, I will give ladies the first choice. Do you have a lady with a question? Can't seem to see any, though. So please, there is a question up there. Can we have a microphone up there, please?
Good morning. Thank you for the opportunity. And I want to also thank our panelists for this opportunity to talk about research. Research is particularly very important for Africa, and it's something I'm very interested in. I'm an Ekan, and I'm a pharmacist in Nigeria. I work with an organization called Global Health Focus. Global Health Focus is a learning partner of this event, and we're a youth-led organization that is really interested in research. In fact, some participants in this conference were given partial scholarship based on their abstracts. We identified a challenge that among healthcare professionals, mostly young professionals, they lacked basic research skills. So that motivated us to start up research courses to teach young professionals how to do research. But we have challenges. The challenges are, number 1, we lack facilitators. How do we get facilitators, academics, to be interested in translating their knowledge on research to young professionals? That's the first question. And I'm addressing it to everybody or anyone that can answer. Then the second question is, after translating the knowledge, we need mentorship. We've also had challenges in getting academics and people involved in research to mentor young professionals. My second question is, how do we address the challenges of lack of mentors in research in Africa? Then the third question is, I schooled in a university basically where research wasn't really given a priority. And I'm concerned not necessarily for me, because I've built myself in research in the ways I can, but for others in the university. And not only mine, most universities in Africa. How do we make tangible researches? How do we get our universities to support tangible researches by young students? Not necessarily what will make some lecturers get their degrees, PhDs, but something that will improve the capacity of people in Africa. Let me give you an example. I was given a topic to do a research on in my final year, and I didn't like the topic because it wasn't relevant. And I told my supervisor I wouldn't do it because it's not relevant for my community. And I had to go look for a research project that was quite relevant for my community, and I did it, and I was happy because there was tangible results. So how do we get our universities to buy into doing researches that can give tangible results? Then the third thing, how do we make research attractive for everyone seated down here? How do we build a generation of researchers from the over 1,300 persons seated down here? Thank you.
Thank you very much. I think he has taken all the time that I had given. So please, if it's one question, let it be one question. It's a 1-minute period of question. So I'm going to give any of you who would like to address his questions, please.
So I'll take that on in the sense that, I always go back to that I've been privileged to be born in Nigeria and won a scholarship when I was 19 to go to the US, and pretty much been privileged I'm blessed to be afforded all my scholarship while I'm in the US. You know, first and foremost, what I always say is that even before I go on, right now, even as a senior director at Johnson & Johnson, I'm still a faculty member of Drexel University, where I have an adjunct professorship there. Why am I doing this? It comes from my heart to really impact what is being impacted on me, to give back. I don't get paid to do this at Drexel University, but I'm taking the knowledge that I've gained from academia, going back to the industry, and I'm going back to the academia and sharing the industrial experience. So, first thing is that I always say is that we have the students or have to be able to articulate what they are doing, how that could impact the society at large. If you can articulate that, you will get folks that will feel that there is something here that I need to be part of. Now, we have to start on a small scale. You can't expect everyone to jump on the bandwagon initially. But once they start seeing fruits of the effort, they will jump on it. We are here to do good and impact lives. That's all life is all about. So that would be my first one. Second, I think it's going to be part of the subsequent discussion on gaps in research in Africa. You know, how do we change that? And I heard yesterday about forming what I call the research clusters. You know, there is no way every institution can have, you know, expensive instrumentation. We talked about exchange rate. We talk about who controls the exchange. There's a limited amount. A lot of the technologies are developed overseas. There's not enough money to go around to buy, you know, MRI for, or, you know, a large NMR for every university. But if we establish a research cluster with dedicated area of focus, maybe in orthopedic research, maybe in biomaterials, but we now bring interdisciplinary team to work together as a team, we'll be able to really significantly advance the science in this area. So I know I'm really passionate about, you know, industrial research, but also more academic research because it's dear to my heart. But more also is Africa is dear to my heart. So we can continue this discussion. I don't want to take too much of the efforts. Yes.
Thank you. Professor Kayumba, coming from the academic perspective, I think you're in a good position to actually address the gentleman's questions now. Please.
Thank you very much, and I'm very happy to contribute. Yeah, he said he has been given a topic. You shouldn't have been given a topic. You should have chosen a topic by yourself. So sharing the Rwandan experience, for example, in our academic research, we are applying the principle of student-based learning. In that system, as a lecturer, a professor, I provide guidance, but you capacitate the student to do by themselves. A good example is this symposium. What we did, only providing guidance on topic, on the content, and then you monitor how students are putting in place all the required for this symposium. That's the role of a mentor. Not only providing those academic skills, but also being passionate to see those young people growing, guiding in whatever they do. Currently, some of them are already finishing their pharmacy studies, looking for a job, developing their career. Our relationship doesn't stop at the campus. Our relationship continues in their careers. Then you provide guidance, you provide support, Whenever necessary, you provide recommendations. Why not be kind of father of those former students? That's how you can overcome this issue of, let's say, relationship between lecturers and the students. But the initiative should come from the students, him or herself, and then you only provide guidance and capacitation on a progressive basis. Thank you.
Thank you very much. I think there is a panel that's going to talk about education versus healthcare, and I'm very sure that will be stressed more on that topic. So coming back to the research in health research and development. So we remember the theme for the conference is about the SDGs, and most particularly SDG number 3. This is an SDG with very many indicators. Of course, there is, it is with facts that health research has significant discoveries, has come up with new therapies, for example, cancer treatment. So there are a lot of discoveries from research that has made health improvement in the populations. So coming back to you, Dr. Mazzarati, one of the indicators in that SDG is maternal and child health, reduction of maternal and child health mortality towards the achieving this SDG. So how do you think the role of research, what's the role of research in trying to achieve this SDG? Thank you.
Thank you. Can I start with just a small introduction about stem cells, les cellules souches. The team who discovered the stem cells said that, one of the team said that about stem cells, what are they? She said, we used to think that stem cells are like Europeans. They do what their fathers of their fathers have been doing within a classic tradition from the father of the father of the son of the, etc., in a classic way. And we have now discovered that stem cells, they just behave like Americans. How do Americans do? How do they do? They see what the neighbor is doing best, and they do. Stem cells have the capacity to dictate, to reprogram the environment to better its own environment. It can reinvent itself wherever it is. It has the capacity to self-renew. It has the capacity to do what it wants to do. It has the capacity to differentiate in anything it wants to be according to its own environment. You want to have an impact, you have to assess your environment. You have to study your environment. You have to research your environment. You have to research your country, your nation, the needs, and then reprogram. And you reprogram in terms of leadership. And I'm going to give you 4 dimensions of a good leadership. First, you have to have a vision. Second, you have to have provisions for your vision. Third, you have to be able to predict. And if you can predict, you can prevent. In terms of research and maternal child health, Rwanda has made milestones. But we know we still have a lot to do. Even though we still have a lot to do, we say the focus on the mother and the child comes not from research, it comes from our culture. We say that the mother is the heart of the household. If the heart ceases to beat, then your whole household falls apart. So, if you want good politics and to attain the SDGs and in terms of mother health and child health, You have to envision a vision which makes the mother the focus of our healthcare, the focus of the way we sensitize our household to do hygiene, to do cooking, to do the usual life of a household if you want to have a better outcome in your healthcare. How do I link it together? I don't know why. I don't know how. But I would just give you a hint. We Africans, we all have mothers who are not chefs, but they cook very well. You want to know their recipe, you will never know, because they can't write it down. But the way they do dosage of salt, of water, of oil, comes out a better chef. So you don't need really to say they don't have research skills. They have research skills. But how do we bring that potential and that capacity to the platform whereby we can make our mothers shine? Because they are chief cook. How do we do that? Do we need really a pathway to SDGs 2030? Or we can just bring what we have now and make it Serena Hotel, chief cook. So if you want to do research to make better the lives of our mothers and our children, you have now to start now and think, not what the professor had said, you have to investigate this topic, but think now what is needed and take the task to heart and to mind to make it happen.
Thank you very much. I'll come back to Dr. Bonnie. One of the indicators of this SDG 3 is about the accessibility and accessibility to safe, effective, quality, affordable, essential medicines for all. So what do you think is the direct effect of research in this SDG indicator?
Thank you. Well, we need chefs there too, I would say. Understanding what are the components of interventions that have worked to increase accessibility in different regions, in different healthcare systems, in different countries. Some of those lessons are transferable across lines, but some of them aren't. So that's why, it is important to understand that although we're talking about research from a global perspective, research is also quite local. And what might work in one system, again, may not work in other systems. And I came across an article just a couple days ago in doing some research for this, but BMC has a great global health journal, and one of their articles was in regards to Ethiopia and Ethiopia's efforts in achieving the MDGs and what lessons could be learned. They had great success, but there were still some improvements to be made. So taking the lessons from others, but continuing to understand what's happening in your own world and your own system is so important. So again, it goes back to getting those data endpoints, whether it's the recipes, what ingredients go into that recipe and how they go together is, I think, very important in getting to understand accessibility and how we get there.
Thank you. Professor Kayumba, how do you relate research and development of vaccines and medicines for both communicable and non-communicable diseases?
Thank you very much. Obviously, medicines and other health commodities are a very key, important pillar for the health system. Health system without such commodities cannot perform. And therefore, a constant development and improving of existing essential medicines, existing vaccines or new vaccines is very key to achieve the SDGs. As far as vaccines are concerned, they are there to prevent communicable diseases, infectious diseases. But currently, people are dying from non-communicable diseases. Recent development have shown that by preventing those infectious diseases, you can also prevent non-communicable diseases. Currently, for example, there are some vaccines, what we call therapeutic vaccines, are under development, or some are really at a later phase of development, whereby, for example, by targeting, for example, some hormones that are implicated, for example, in vasoconstriction, then you are preventing hypertension, for example. By vaccinating against hepatitis B or vaccinating against human papilloma virus, you are preventing development of such infectious diseases into cancers. And therefore, for example, the case of Rwanda, for those coming from abroad, the vaccination against human papilloma virus, the one responsible for cervical cancer, is up to 95%. Meaning, by vaccinating 95% of schoolgirls, you are preventing the appearance of cervical cancer, and therefore are contributing to their longevity. That's how I can really link research and development in terms of drugs to the achievement of SDGs 3.
Thank you. Coming back to Dr. Badejo, you mentioned of the this new technology involved in improvement of the health system. So how are we going to use the research in trying to, how is it going to affect the efficacy and the safety of the new medical interventions, and of course the change of the practice of medicine? And this is, how is it going to benefit the achievement of SDG 3?
So, when we look at one of the tenets of the SDG 3 is essential surgery. There was a recent paper published in Lancet that talks about 5 billion people have no access to surgery. About 143 million people today require surgery. But if we have to take it further, I always look at some of the areas that we can quickly have an intervention. Let's think about, I'll go back to the area that I'm really passionate about, is in trauma. When we were looking at how do we close wounds, currently, there are many medical doctors and surgeons or students, medical students here. Right now, if someone has a laceration or a trauma, you close the wound by suturing it. That's normal. But the patient has to come back to have the suture removed. One of the inventions that we put a lot of efforts in developing research towards is how do we really transform suturing, change that, and bring the cost down. We develop a product that instead of suturing the wounds, you can literally glue the wounds. When you glue the wounds, the patient can actually go home, take a shower. The patient doesn't have to come back 4 days or 7 days or 14 days later to have the suture removed because the glue just slots off. So when we're looking at this and we're asking ourselves, when we're doing the research to try to understand how do we come up with this material that can literally disrupt, because that's the area that I'm really focused on. How can I disrupt the current standard of care to bring a significant improvement and bring the cost down? So being able to develop this suturing material and sequentially going through additional research in terms of assessing the safety and efficacy, starting with mice, going to rabbits, from rabbits, once it's showing promising, going to pigs, before we even go to human. Because by then we will have collected enough safety data and efficacy data that gives us a higher level of confidence that when we go into human, the clinical outcome is going to be confirming what we've already seen. So we have to do sequential and go through sequential analysis in terms of animal models, finally going to human. By the time we did about 120 patient human clinical trial, we came and the FDA gave us an approval to launch this product. So instead of suturing, you literally just glue the wounds. The patient goes home, take a shower, 7 to 14 days later, the glue just slots off. The patient doesn't have to come back to the hospital. We're able to bring the cost down because now you don't have to, the patient doesn't have to go back and pay for the surgeon to have the suture removed. So thinking about the clinical outcome at the end of the day, thinking about the patient benefit, thinking about reducing the cost at the beginning of your research will help you to direct and focus your efforts around developing the right intervention to reduce the burden of trauma and surgical repairs. Thank you.
Thank you very much. I'm now going back to the audience. A set of questions again. Of course, as I've mentioned earlier, ladies first. Do you have a lady with a question, please? Microphone, please. One question, and please mention who you're addressing the question to.
Thank you very much. My name is Christophe, and I'm Public Health Regional Assistant for Africa International Federation of Medical Associations. Then, I'm from Rwanda, and I'm also passionate at global health research. And my question is addressed to Professor Kayumba, yes, our dean. Dear Doctor, as VC pointed out yesterday, University of Rwanda is among the top universities, is on the second place in East Africa, and research is among the top contributors. And as Mr. Anikan from Nigeria mentioned, he talked about the challenges we are facing, still facing in, not only in Rwanda, or across the world. I would like to know, yes, among those challenges, he mentioned that we have lack of facilitators, we have lack of mentorship, and most importantly, funds. We need funds, and we are still facing the same problems here. So as a member of staff, in your contribution, personal or professional support, so what can you promise us to promote research among healthcare students and also to bring Rwanda on the first place? And I think this will be suggestive to other universities. Thank you very much.
And let's please be brief about our questions, okay? Please, there was a lady there that has a question.
Thank you so much. My name is Gaudensia, and I'm from Uganda. So my question goes to all the panelists. Back in Uganda, most students and health professionals depend on grants to do research, and we all appreciate the importance of research to achieve the SDGs. So this, most times, has affected the results people get from research, because sometimes they want to please the funders, or rather, people write proposals citing out problems just because that particular problem will enable them get their grant. So sometimes the most pressing problems are left out because of that. So how can students and health professionals learn, or rather, manage to fund their own research? Like, say, for example, if it's possible for the regulating bodies to reduce on their fees that is paid to carry out research. Thank you.
Thank you. Keep reminding you, please be brief about your questions. Just shoot the question, okay? Can we have a question from this side, please?
Yes. Thank you very much. I'm here by the names of Numukobwa Darila. I am from Rwanda. My question, I think, can be addressed to anyone because it's general. I have a question about, while I have been trying to work on to have a research about public toilet hygiene, and I have gotten experience that people have tried to gather the information from different institutions and communities, and I got a problem because people were not feeling free to provide the information because they thought that I would go to report them and expose their bad actions. So sometimes you find it's not easy to get information from people. So I would like you to show me how we are going to convince people to provide us bad things they are doing in their communities so that we can impact them back. But how can we do that, please? Thank you.
One more last question, please. This gentleman here.
Good morning. Thank you for giving me the chance. I appreciate all this discussion. And I just specify appreciation for we have to choose our research regarding our community needs to assure our sustainable development goals in our communities. I have a small experience that when me and my colleague choose the master degree research title, we have two ways of choose. The first one, I will choose a research title that most easy for me, and the second choice, I choose the most needed for the community. So I think we have to choose what our community needs. My question is, regarding the multidisciplinary researches. In my country, I can't find multidisciplinary research. I can find the doctor make research, pharmacists make research, nurses make research. But what is the importance and the effect of multidisciplinary research in primary health care and in curative health care on our community needs and the global impact? Thank you very much.
Thank you. Now going to give a chance to the panelists. I think the first question was addressed to you, Professor Kayumba.
Thank you very much. We have to recognize really the capacity to conduct research is still an issue in our developing countries where available resources are being deployed over different priorities. But we have learned during this Rwanda reconstruction after the genocide that few means should be put and should be well used. And experience has shown that with a few resources we have and progressive capacity building, we should be able to contribute to the world knowledge. The good example is currently, for example, our university won, do you know how many African centers of excellence? 7. Why did we win that? Writing good proposals, taking time and write those good proposals, submit and defend them. It's always possible to write and get and win the grant. Under this mentorship I was talking about, whatever you draft as a research proposal, as far as it is focusing towards SDGs 3, that's our concern, absolutely you will get financing. I know we have partnering institutions. We are sitting here not because of finances of the university, but because the cause we were pledging for was reasonable. We got whatever support we needed. The Rwanda Biomedical Center, I see here the Rwanda Social Security Board, and the other institutions, they always have an area tackling research. So writing a good proposal, submitting to those institutions, negotiating, absolutely you have funds. With the few resources we have, it became a policy here at the university and in front of my vice chancellor, the research that is not aligned with SDGs goal might not get support or might get hardly support from the university. But if we do through SDGs, meaning we are meeting the need of our population, and absolutely there is no reason we not get a financial support we need. Capacity building is not only for financing, but also skills. As I have said, the way we are teaching currently is a student-centered learning, where a student is trained on how to work on his or her own, but under, of course, orientation of lecturers and mentors. And that way, at the end of the process, we choose together the topic. We assess the available resources or the potential supporters for our research. And therefore, together, we submit whatever necessary, and we do whatever necessary as pledges and advocacy to get those support. So only the secret is capacitate the student, mentor and orient, and accompany. At the end of the process, absolutely, our research proposal will get support, both finance and whatever we need. Thank you.
Yes, I think research is a very big and wide topic, and this also comes in the panel for education versus health system. So I'm very sure most of your questions will be answered in this. I'm just going to conclude this panel by giving my panelists 1 minute of conclusion remark. Thank you. Starting from you, Dr. Badeja.
Thank you. It's been a privilege to be part of this esteemed panel to share and talk about research. I will always start that at the end of the day, the patient's clinical outcomes and accessibility should be our North Star. So in my goal in life is to continue to put that as a part of the front center of all the decisions making that I do. But at the end of the day is, what kind of research I'm doing, how does research translate to better clinical outcomes and improve the standard of care for the delivery is what I'm always focusing on doing. And I hope all of you take that as you are living here today. And I will remiss if I say that, if I don't mention it, that research into delivery and a better clinical outcome have to be multidisciplinary. It cannot be done by one segment of the healthcare system. Thank you.
Thank you very much. I think I have to say that research is very expensive. It is expensive for the student, it is expensive for the university, it is expensive for the country and countries. My dream is to see African countries live up to their pledge to make some percentage of their GDP dedicated to research and science discoveries. That's my dream. If that's it is, students shouldn't really be, how can I say it? Students shouldn't be in a situation whereby they struggle for their scholarship and they struggle for funds for their research. University should have, this is the Vice Chancellor will love it, university should have enough funds to do what they have to do as academic institutions, but to deliver to the country up to their mission. They are in the driving seat of the mind and the heart of a country. They have to have enough funds. And the countries we make a priority for infrastructures, road infrastructures, hospitality infrastructures. We have to make our universities shine in terms of funding so that we can ask them and request and demand of them to deliver the capacity to generate ideas of 20-30 years. That's really my wish, to see Rwanda take away some budget, inject it into universities to make our academic institutions centers generating not only knowledge, but doing which is evidence-based. I'm going to finish giving you one small example because it was about maternal and child health. There is a hospital which is 2.5 hours from Kigali. It is called Muhororo. Both ways to go, it is 5 hours drive. If they want to get provisions of blood, they have to do 5 hours drive. Imagine if a mother is on surgery table in need of O negative blood. They don't have that grouping in their small bank fridge in their hospital. They have to drive 5 hours, or they have to transfer the mother from Muhororo to Kigali, 2.5 hours. How many chances does she have to survive? 0. But with the capacity to deliver blood with drones today, we can deliver blood to that hospital within a range time of 20 minutes. So the mother can be at the table, being in need of blood, just with a call, you get the blood at the table surgery. It is about research, it is about investment, but it is most of all about a life. Do research, but think about the life which will survive because of your research. Thank you.
Thank you. So for me, my last point is that although we know that capacity building has to happen in order for more research to occur, whether that be skill-based or financial, research still needs to occur in the meantime while we wait for those to come to us. You can be grassroots about it. You can look to work with other research projects that are already ongoing. As a student, that's a great way to get involved. You may not be the primary investigator to start, but you will gain so much experience if you can add yourself to an existing research team, or if you're working in a clinic or an institution, getting some support from some of the other clinicians and trying to push forward something small. I think that's a really great way to start, so you will get that experience, you can build those skills, and the need is out there. There's plenty of research projects to be done. So identifying something in your immediate area is, I think, a fantastic way to get started with research. And mentors don't only have to come from the academic environment, they can come from folks that you're working with. They could come from other institutions or even across country lines. And forging those relationships and networking is also another great way to identify opportunities for research and again, to start getting involved. It's gonna start small, but the more you do, it's going to be like a ball rolling down the hill. It's going to get bigger and bigger. So I think for me, that's what I'd like to give to you students as you start going forward in your career.
Thank you very much. My last take home would be innovate or you disappear. Without innovation, you will not really continue to exist. But that innovation should be well negotiated with different partners. We know that conducting research lonely in your corner it cannot help you to advance. A multidisciplinary approach is very key. And that multidisciplinary approach should include potential or private or industry partners, because they need your research to innovate, but you need also their contribution or to conduct research. On our side as academicians, we should show up as a potential or client to those institutions. We should show up as capacitated institutions to compete with others and won those grants. And therefore, multidisciplinary approach indeed. Thank you.
Thank you. Thank you all. Thank you very much. Please, much hand clap to the panelists for today. Yes, and of course for myself. Please, hand clap for myself too. Okay, in conclusion, thank you also for attending, and please, let's go do research. Let's go do a multidisciplinary research, and please remember it has to be in relation to the good health and well-being of our populations. Thank you very much for today.
Good morning, everyone. We see now that we have a full house. Welcome for those who arrived late. So again, a big hand of applause for the panel and for the topic for today. So just to do sort of a short summary for what just took place. There is the fact that Africa actually, when it comes to research, focuses on healthcare and agricultural sciences. But in spite of this, when it comes to the education level of research skills, there's still to be improved there. So we also thank Dr. Ibrahim on the importance of starting small, even when you have a big vision, and also the importance of actually still doing research at the grassroots level, right? So also in the sense of when you do multidisciplinary research across sectors, you might be able to bring down costs and have better outcomes. So again, thank you for those who were able to participate. The impassioned plea of the audience on the importance of mentorship and on the importance of mentorship and having funding that is relevant to the topics that they're actually researching in. So we would like to go on to the next plenary session. We welcome the moderator today, Noela Bigirimana, the strategic advisor at Rwanda Biomedical Center for the next plenary session that focuses on universal health coverage.
Okay, welcome. So while she's going on the stage, I will try to recap the summary in French for those who come from DRC and requested. So ce qui s'est passé dans cette session qui vient de se terminer, c'est que dans les recherches, notre topic c'était les recherches dans la santé. Et ce qu'ils ont dit, c'est que les recherches ne sont pas vraiment globales. Il faut savoir faire des recherches dans nos communautés pour pouvoir aider nos propres populations. Donc, nous devons vraiment encourager les jeunes à faire sortir dehors et faire les recherches eux-mêmes. So, ce qu'on doit faire, c'est vraiment pensez-y, mettez ça dans nos cœurs et travailler pour diminuer le prix et donner des résultats qui sont meilleurs dans nos communautés. Merci beaucoup.
Yes, just one last short announcement. For the health professionals that are looking for CPD credit, they're going to be having their names taken down at the OC office. For those who were able to go there yesterday, it's going to be taking place during tea break and lunchtime. Thank you very much.
Thank you.
Thank you very much. So like they mentioned, my name is Noera Bigirimana, and it is an absolute pleasure to be moderating this session on universal health coverage. So I would like to invite the panelists here on the stage, and we're going to have Dr. Solange Hakiba. Welcome. We have Dr. Githinji Gitahi. Welcome, sir. There's also Dr. Abdallah Uwihoreye. So as we welcome them, I can talk a little bit about the flow of the plenary. So we're going to start with a short video from I would say a very important global leader who will be sort of sharing his experience of universal health coverage. And then we'll have a keynote speech by Dr. Coutinho, who's the country director of Partners in Health. And then we're going to go ahead and proceed with the panel and hear what the panelists have to share and see what their perspective is in terms of universal health coverage. So if we are ready, and we can go ahead and cue the video. Thank you. It's true. It's a very important message. Maybe we should hear it again. No. And thank you for, I think Sir Mahmoud has set the stage for the importance of social justice element of universal health coverage, the notion that health is a human right. And I think it transitions well into our keynote speech today, and I would like to welcome Dr. Coutinho, who's the country director of Partners in Health, an organization that is known for its for championing social justice across the world. Welcome, Doctor.
Thank you, and good morning, colleagues and friends. I would start by congratulating the visionaries and the organizers of the WHSS that brings together this very unique gathering of players who are important for health in a very much one health concept that appreciates that health and its genesis comes from many, many actors and players and institutions and conditions. My talk today is about universal health coverage in the context of Sustainable Development Goals. This morning, I left my home, where I work in Rwanda. It's 2 hours away towards Tanzania, in a village called Rinkwavu. It's a small village of about 1,000 people. We have a district hospital, and we serve a district of about 300,000 people. In my village, we have the hospital, we have a school, we have 5 shops, and it is a true village. And that's where, as executive director, I live and work, not in Kigali. When I come to Kigali, I get culture shock because I've forgotten what the city is like. And we do that purposely because we want to be at the front line of universal health coverage. Because every day I wake up and I see the population that is facing the challenges of living in rural areas, surviving in rural areas, and maintaining their health in rural areas. So my talk is going to be about the journey that brought us to where we are, articulating about universal health coverage and Sustainable Development Goals. And that journey really began when it was articulated and recognized that health is a human right. Now, when we hear that today, it's so obvious that we wonder why we did not just understand from the very beginning that health is a human right. But oftentimes in colonial Africa, the health of the population was only evaluated in terms of the ability of that population to produce cotton, coffee, copper, and gold that could be exported from Africa to benefit others. So health was a pathway to economic enrichment for others, or health was a pathway to convince people to change religions and become Catholic or Anglican or Islam. Health as a human right, fundamental to every human being, had not been articulated. To me, that was really the beginning of the journey to where we are today. The second step in that journey occurred when I became a medical student, 1978, at Makerere in Uganda, when there was a declaration of health for all by the year 2000 at Alma Ata. And as a first-year medical student, very excited. By the year 2000, there will be health for all. And of course, alas, the year 2000 came, and not only was there not health for all, I was deeply immersed in trying to respond to an HIV pandemic that looked as if it was going to wipe out my country and others. So that was really the second step. The third was a recognition that, in fact, if health for all was going to happen, it had to be driven not by the private sector necessarily, but by national governments supported by international institutions. That it is impossible to provide health for all for the entire population unless you have good leadership, good governance, and the ability to understand how you will tackle the burden of disease in these countries. Unfortunately, even as that recognition happened, many factors led to the shrinking of many economies across Africa. And with that shrinking of the economies, the finances required to fund health for all, the finances to fund a proper intervention into health were lacking. And in many, many countries, we got a market failure and a collapse of many of the health systems that are required to deliver health. But as the years went on, there was a recognition that, in fact, without health, two key areas for the global economy and for the world would suffer. One was that health could lead to security issues globally, poor health, that is, and that poor health could have an economic impact. And there are two diseases that have exemplified that. One was the HIV epidemic, and the other, more recently, is Ebola. And these two diseases have triggered the understanding that poor health is not just an individual problem, but in fact is a global problem that can affect nations. And as I teach my public health students, I always tell them cynically that as soon as something touches the security of the world or the economy of the world, people pay attention. And they will translate that attention often into resources to tackle, in this case, health. So the next step that brought us to universal health coverage were various declarations that prioritized health or aspects of health. One was the Abuja Declaration that set an investment of 15% by countries into health and health sector. The others were Millennium Development Goals that were set and gave targets for aspiration and embarrassment, because when you set a target, you are trying to inspire people to aspire to achieve those targets, but you also hope to embarrass those that fail to reach those targets. In 2001, we had targets around a very specific disease, the Angus Declaration, that focused on HIV and AIDS and gave a focus that could both provide targets and funding, and more recently, the Sustainable Development Goals. But even as these were set, it was clearly understood that many countries were going to be operating from a broken health system. Broken from the point of view of financing that health system, broken from the perspective of the ability to supply, from the supply side, to supply the services that were needed, and broken from the demand side because the consumers were not even aware of their rights or that they could demand for better quality healthcare from the leadership of their countries. And now, I would like to use Rwanda as an example, because Rwanda, 23 years ago, at the end of genocide, inherited a completely broken health system. Broken because of years of suboptimal colonial investment in health. Broken because of previous neglect for health. And finally broken by everything that took place during the era of genocide. And I think it is quite proper that this conference, for the first time in Africa, has come to Rwanda. Because Rwanda is an example of a country that has built itself from the ashes of destruction in many, many ways. But I will focus purely on the health side. And I came to Rwanda as an outsider from Uganda, so in a way I can see it better sometimes than those who are part of it. Because you get used to something and you don't realize that others don't have it. And there are many examples that I could give, and I will mention just a few. So Rwanda, in rebuilding its health system, focused on primary health care. And I call it primary health care plus, because the primary healthcare system in Rwanda includes over 46,000 community healthcare workers. Every village has got 3 community health care workers. Absolutely unique in any country in Africa. I don't think any other country has that number per population of community healthcare workers, which means that right at the forefront of medicine, right next to where I live, we have a community healthcare worker who can take care of malaria, diarrhea, provide family planning, support HIV-positive people, weigh children, refer them for malnutrition. In fact, the system in Rwanda goes back to the 1978 Alma Ata Declaration, Health for All by the year 2000. So you cannot provide universal healthcare unless you have a primary healthcare system that goes the last mile to where people live. The other is that Rwanda's invested in a tremendous health infrastructure system that starts clearly from a community health worker to a health post, to a health center, to a district hospital, and then to various levels of referral hospitals. Because the burden of disease cannot be managed only at the front line. And to give the front line confidence that they are able to manage malaria or HIV or TB, they need to be able to refer further and further upwards towards specialized care. And this has been put in place across Rwanda. The third is that Rwanda is one of the few countries in Africa that is about to achieve 90-90-90 with regard to HIV. 90% of the population tested and knows their HIV results, 90% on HIV treatment, and 90% have proper treatment with suppression of viral load. This is very, very unique, and Rwanda needs to be really congratulated because it's an important pillar for universal health coverage. And the other great achievement here towards universal health coverage is community-based nationwide health insurance. Because a major pillar of universal health coverage is the ability to finance healthcare without creating financial catastrophe in sick people. And by providing a community-based, affordable health insurance, Rwanda again has shown the way of how the state and the leadership can put in place a nationwide scaled-up system that assures the population through a very small annual contribution of access to a package of healthcare. And I could go on, but Rwanda has many things to learn, and I hope that in your few days here, you will be able to share with your colleagues in terms of the pathway towards universal healthcare coverage. But there remain many challenges, not just for Rwanda, but particularly for many African countries. And I will list just a few as I wind up my short talk. First is demography. And the good news is that we are living longer, all of us. Our life expectancy ever since people are getting treatment for HIV is moving from the 40s to the 60s. So people are living to 60 years and beyond. And that's good news. The bad news is that as you turn 60, as I am turning soon, you start getting diseases you would not have got if you had died earlier. Start getting non-communicable diseases, you get diabetes and hypertension and cancer and other diseases, which means that the health system has got to adapt to the fact that demography is leading to a different and bigger burden of disease. Demography often means urbanization as well, and more people are living in cities. Kigali is one of the fastest growing cities in Africa. And urbanization comes with its own diseases of pollution, of stress, and other negative side effects of living in the city, which I don't see now when I live in the village of Rinkwavu. The second big challenge is the environment, especially for Rwanda. Environmental degradation, soil degradation, changes in rainfall, changes in temperature are becoming visible in Rwanda first in the area of food security. in the ability to produce enough food. And the genesis of health comes from nutrition, comes from safe water, comes from shelter, and many others. But without food, there is no life. And so Rwanda and many other countries have got to invest in aspects of environmental management. The fourth big challenge is the youth in this room who represent the youth across Rwanda and the youth across Africa. The youth who are getting more skills, but after graduating are not getting sufficient employment. A situation where in Zimbabwe 90% of people are unemployed. And if we are not able to create employment opportunities, if we are not able to invest in the economy and the development of the country, we will not be able to fund an insurance scheme that provides universal health coverage, because employed people are the ones who are generating revenue. So this is an area that one must look at, and how you work within a country to generate the economy, to stimulate the economy and generate employment. The other challenge is there are many emerging emergencies that one must be prepared for. Emergencies like epidemics. Ebola nearly shut down West Africa. Emergencies like refugee and population movements, and I wish to hail Rwanda for offering to host 30,000 stranded Africans in Libya, because that is what progressive governments do. And even in the context of universal health coverage, we need to make sure that universal health coverage is not just for the citizens of a country, but for anyone within the borders of that country. And anyone who has visited a refugee camp in Rwanda will know that every single refugee in this country has access to the same standard of health care as a Rwanda citizen. Something else to celebrate in Rwanda. The other trends we are seeing are a reduction in external funding. It's ironic that as Rwanda develops, sometimes its access to external funding is reduced. On the other hand, it's teaching Rwanda how to survive without that external funding, and in the long term, that will really be good. So as you listen to these challenges, and I have left out many because of time, it becomes very clear that challenges of environment and demography and employment and so on and so forth are actually challenges that are within the Sustainable Development Goals. And if you look at all of those Sustainable Development Goals, they are really the backbone and the foundation of keeping a population healthy. If we could achieve every single one of them, our population will not only be healthier, but in the event they are not healthy, they should be able to have better access to healthcare, fulfilling the mandate of universal health coverage. So I see the two as very interlinked, and I would like to congratulate the organizers for having seen the need to talk about that. I look forward to listening to the panelists who will add more wisdom on this topic, universal health coverage, in the context of Sustainable Development Goals. Thank you very much.
Thank you, Dr. Coutinho. And so we're now going to move to the panel. So I think we've set the stage for this conversation. We've talked about universal health coverage in the context of access to basic health services. We know that more than 400 million of people around the world don't have access to essential health care like immunization or skilled birth attendance. And we also know that the second part of that is about financial protection, and that has been said. We know that 150 million people, at least 150 million people every year are pushed further into poverty because they're seeking that care. So I hope with the panel today, we'll be able to not only define the stakeholders involved along the lines of showing that it's a commitment that takes many, many people. And with defining the stakeholders, you'll be able to see what progress, opportunities, or challenges, and how, in their capacity, with their background, they're able to help us see this universal health coverage topic in the context of SDGs. So I can introduce them briefly. It won't do them justice. They are amazing people, but we're running out of time, so I'll have just a few lines for each panelist. So we have Dr. Solange Hakiba, who's the Deputy Director General at the Rwanda Social Security Board. And so in her position, she's able to oversee and drive the strategic planning for many insurance health schemes, including two of the most important ones in Rwanda. One is Mutuelle de Santé, which covers the informal sector and the formal sector, and one that covers the, which is called Rama, and covers civil servants. And so prior to that, she has had multiple roles. And so we'll be able to see that perspective of somebody who's been involved with designing benefit package, but who's also worked with civil society organization. And so immediately next to Dr. Hakiba is Dr. Gitinji Gitahi, who's the CEO of AMREF Health Africa, and it's a large organization, large NGOs that works across Africa in 30 countries, and serves over 13 million people. So we'll have that perspective of somebody who works with an organization that has a vision for a lasting health change that looks at the health system strengthening perception. And then we also have Dr. Abdallah Uwihore, who is the country director for the Vision for a Nation Foundation. And so with his organization, he's able to help with access to healthcare. One thing I noticed, everyone on this panel is wearing eyeglasses. So that's a very important perspective to be brought in. And so he works with the training, with the outreach and the screening, making sure people have access to eye care across the country. So without any delays, I would like to begin with, asking one question for the panel. But before that, can you, for each panelist to set the stage for their perspective, share like a 2-minute address of how you perceive universal health coverage in your role, in your previous roles, or what you think is important to communicate to our audience today. So Dr. Hakiba, I'll start with you.
Thank you very much. Good morning, everyone. It's an honor to be here and to share my perspective. I've had the chance to be working now for health insurance schemes, but in the past, I've been on the other side of health insurance. I was working in the Ministry of Health, who is in charge of regulating the health services delivery in the facilities across the country, both private and public sector. So what we do today is, as Noella said, in the Rwanda Social Security Board, we have 5 schemes, and 2 of them are health insurances. The first one that she mentioned is the community-based health insurance, commonly known as Mutuelle de Santé. And the Mutuelle de Santé covers the entire country. The way it was designed is that in order to attain the universal health coverage, we first had the formal sector health insurance, meaning the public sector, civil servant, but also the private institutions that were willing to enroll their employees into our health insurance were also considered. So at first, Rwanda started with the formal sector coverage for health insurance, but then after that, in order to attain the universal health coverage, we launched the community-based health insurance that was tailored towards the informal sector, which was the hardest to reach. And may I allow myself to say the most needy in terms of health services, in the sense that they don't earn monthly salary, and therefore they are classified as the most financially vulnerable when it comes to out-of-pocket expenditure for health. So the community-based health insurance has been designed around what we call the Ubudehe database. It's a socioeconomic categorization of our population where every citizen of Rwanda is categorized based on his or her wealth or possessions. And that is done by the community, so that if I own a car, if I own a house, the community around me knows what I own and whether I can afford 1, 2, or 3 meals a day, whether my kids can go to school. Basically, they know everything about me, and I do the same for them. So they categorize me in the Ubudehe database that ranks the population into 4 categories, 1, 2, 3, and 4. And based on those categories, a premium has been set for the payment of the community-based health insurance, an annual premium that is paid for the year of the community-based health insurance that runs from July 1st to June 30th. So the community-based health insurance covers health services in all the public health facilities. And I think Dr. Mazzarati earlier mentioned the different succession in our health system, from the services rendered by the community health workers to the health post, and then the health centers, and then the district hospital, provincial hospitals, and finally at the referral hospitals. So respecting the referral system allows our people, our affiliates, to access care as they need, and they are entitled to pay for their co-payment. This has helped us a lot because it has given access, it has beaten the financial barrier of our population to access care, and it has made a huge difference. I think it played a key role in attaining the MDGs, in providing enough utilization of health services to enable them to develop and to grow in order to not only increase the services, but also the staff and the consumables. So the other scheme that does health insurance is called the medical health insurance. It used to be called RAMA, but not anymore. But people still refer it as the ex-RAMA medical insurance. And this is the one that I said covers the formal sector. We also work on occupational hazards and safety at work, but also old age pension and maternity leave. So it's, they all do a lot with health issues, health services, and as Dr. Coutinho said earlier, the espérance de vie in English, life expectancy. As the life expectancy is actually growing, we will be dealing with more of the non-communicable diseases. And when we look at our pensioners in our old age pension scheme, this is something that we'll need to be looking at more and more to make sure that, because all of them are in one of our schemes, health insurance schemes. So we believe we have unique insight on the health and the wealth of our population. Thank you very much. Oh, sorry.
Thank you, Doctor. And I think it's important to mention that under the Rwanda Social Security Board, and Dr. Hakiba just talked about coverage, in Rwanda, the community-based health insurance, which is the first scheme that she mentioned, covers the informal sector, covers nearly 90% of the country. And I think that's unique to our country today, and what we're able to see, sort of, she's giving us a behind-the-scene look at the decision points that happen when people are seeking care, and how they think about how do we take away that financial barrier and make sure we cover more people. Thank you, Doctor. And so I'd like to ask Dr. Gitahi to tell us about what is with your work, what is your vision? What does universal health coverage mean for AMREF Health, for you as a health professional with your extensive experience?
Thank you very much to the moderator. And You know, I can sit here all day and listen to Dr. Akiba. I am amazed at what Rwanda has achieved. So every time I listen, I'm just in awe and respect. I'm just like, keep going, keep going, keep going. So maybe we should just give the mic back to her to continue. But before that, I'll say a few things. First, I'm honored to be here to introduce myself for the young people. You can find me on @Daktari1 on Twitter. That is my introduction. The next thing is I work for an organization that provides systems building across Africa. It's a 60-year-old organization called AMREF that works in 35 countries across Africa. It's headquartered in Africa, in Nairobi, and that's where my office is. And people always ask us, are you an international organization? You are headquartered in Nairobi? And we say yes, because there's no other organization actually, but many of them are trying to change now. And I was really happy to listen to Otakutinho saying how they have a focus in the rural community, because that's the only way you can understand the needs of the people, and that's the only way you can design people-centered programs for primary health care. By living with the people, by understanding the people. So for us, we have over 1,000 staff, and they all work in the communities, and very few of us are at headquarters, but we have offices also across the world for fundraising and partnerships, because most of the development partners would be in Europe and North America. So our offices there are purely for fundraising and partnership. The other thing I would like to say is that I'm glad to be on this panel and not the earlier one on research, not because I'm not a professor, which was also intimidating. There were so many of them on the panel, but also because that panel dealt a lot with what I may call the present of the current healthcare situation in Europe and North America and the future of healthcare in Africa. And in this panel, we are dealing with the past and the current of healthcare in Africa. It's really the fact that for us, we're really excited to hear about stem cells, 3D printing, and all these things, because they're the future. But every day we face, death from diarrhea. We face death from basic diseases. Many years since the scientific or the sanitary revolution in Europe, which saved many children and people when they just decided we'll have the Public Health Act, everyone will have access to a toilet, everyone will have access to water. We're still losing millions of people to diseases which can be sorted out through just basic sanitation and water. And therefore, for us as an organization, whereas we respect research and we listen to researchers and we work with them, a lot of our time is spent on primary health care. It's spent on understanding what the requirements of the people are at the bottom of the pyramid. So I am honored to be here to think about that. But then there is a link between what the earlier panel talked about and what this panel is talking about, because we need research, we need innovation, because then that helps us to leapfrog, to accelerate our healthcare provision, to accelerate all these things. But what really increases the rate of diffusion or acceptance or integration of ideas is a well-run health system and existing systems for health. And that is universal health coverage. I think if you brought an idea now to Rwanda, it is easier to work with the Rwanda government to diffuse the idea to the people and to the health system and to make it accessible than if you went to a country that doesn't have a properly working health system. So for me, for universal health coverage, I think earlier when I looked at the notes, I was asking, is universal health coverage achievable? So I look at the African context. And I'll say, looking at Rwanda, yes, it's achievable. I think the question is how. If we look at universal health coverage, we have three key areas. We have the issue of access. We have the issue of quality. We have the issue of financial protection. In access, I really want to refer to the keynote address, because access is all about social justice. It's about social justice. It's about the fact that the death of a child is the responsibility of the country. It's not the responsibility of the parents. The responsibility of the parents is there, but at the end of the day, it is a human right. It is a human right, and it is something that is enshrined in our constitutions. It is something that is enshrined in the UN Convention. So when children die and mothers die, we must ask ourselves across Africa, have we provided the rights to that family or to that child who died, and what do we need to do? So we need to look at universal health coverage, and specifically the access area, more specifically through a human rights eye. And I really like the reference to a social movement, which was in the video earlier. The next issue is quality. I think a lot of times our governments misunderstand what quality means. And in many governments in Africa, quality is providing cancer centers, quality is providing expensive MRI equipment in the hospitals, quality is providing more and more ICU beds. Well, in actual sense, if you look at the definition of quality in universal health coverage, it's not about benchmarking with already existing healthcare systems in Europe and North America. It's about providing the quality that is able to give the safest available care to the person seeking it. And that is why, you know, in many of our areas, and I know Rwanda is also affected and many other countries in Africa, you know, patients are happy to find a healthcare worker to begin with. They are happy to find a healthcare worker. They may not discuss complicated care at that point, but they are happy to find a healthcare worker. I think if you look at our disease profile, and you look at cancer, for example, 75% of our cancers get to the hospitals at stage 3 and 4. And therefore, when we continue to kind of invest in oncology, continue to invest in cancer medicine, we are basically saying we failed to prevent some of these preventable cancers that were being talked about here, and now the only thing remaining for us is to wait for them to come and die. And therefore, let us invest more and more in the facilities where they can die peacefully. Instead of saying, let us go back and stop the flow of the river. So primary health care should consider quality as what is available for the person seeking it, not what other people do. Because quality is a benchmark term. Quality is about, do you have more quality than the other? You know, there's no end game called quality. So I think we need to redefine that for our politicians. And I'm really, you know, Rwanda is a good example for many African governments. And the final part of UHC I would like to talk about as I close is obviously the issue of financing. Financing has been a critical problem. You know, I was in a meeting recently where USAID and WHO and I think World Bank were presenting a paper that shows that in the Millennium Development Goals era, many countries in Africa have deprioritized health funding. The reason is because there was funding for it. So because Global Fund comes to you and says, we are going to help you fund your HIV area, the government removes money and then takes it to roads and infrastructure and other things, instead of then prioritizing it within the healthcare sector. So the data shows clearly that the Millennium Development Goals era did not help in increasing healthcare expenditure in very many countries, which is a concern because we must think about domestic financing. When you think about universal health coverage, WHO says, think public. Think public. Because, as was said by Dr. Coutinho, it is the public sector that has the responsibility of providing universal health coverage. And the role of private sector is innovation, it is efficiency, it is creating macroeconomic dynamics that support increased healthcare provision and affordability. So I think these are the first points I would like to note, and I'm sure that we'll have a more engaging discussion.
I'd like to ask Dr. Abdallah Wihoreye, what is your vision? What is your perspective of universal health coverage?
Thank you very much. I think I'm not going to go out of what my colleague said, but I look it in 3 dimensions: the equity in access to health services that he talked about. And I think people who need service should get them. Not only those who can pay service. All the people can have equal access, the level of quality, because it's not just a matter of having access to service, but the quality of that service. That's where I don't agree with the free health services, because sometimes its quality is questionable. And then the third is financial risk protection. Also, I'm going to the example what Hakiba said. So Rwanda is at another stage in terms of community-based health insurance. Because if you look at other countries, they have big barriers because of not having that. And the way Rwanda is structured, actually it helps to accelerate the universal health coverage. For example, in Ghana, Ghana has national health insurance schemes, which is mainly a pro-poor policy. Yet, majority of poor people, those vulnerables, are not able to pay premiums because they have flat rates. But in Rwanda, we have those categories. We have those categories where it's very easier to know this category can afford at this level. So coming at what Vision for a Nation is doing on universal health coverage, Vision for a Nation is supporting the Ministry of Health to make sure that eye health is at all levels, especially at primary. Because when we started, the service has been at not even secondary, but tertiary level. As you said, you can see that among all of us on this panel, we have glasses. But what about the people who are sitting in rural areas? So Rwanda, that 2 million people. So this brings also the other aspect of task. Achieving universal health coverage doesn't need a country to be a rich country. Because when we started this program with the government of Rwanda, Dr. Akiba knows that because she was PS in the Ministry of Health, everyone was saying, no, only optometrists can do that. And we said, how many optometrists do we have in Rwanda, for example? We had like 3. So all those 3, can they manage all cases across the country? The answer was no. So, but we developed the curriculum, now endorsed by WHO, and WHO is telling now other countries to use. Now, in all, as per the pyramid, referral hospitals, provincial district government is supporting the poor, around 20% of our. To me, also I can emphasize on that, the political willingness and ownership is very key. Thank you very much.
Thank you. Keep coming back. So I would like now to dive into the how. And the panelists have started to mention some of it. So I'll start with one question as I ask the audience to prepare for, after in delivering universal health coverage, is deciding what services and policies that have to be prioritized, because it's about priority. We have a lot of demands, not enough resources. How do you go about deciding what to include in it? If one can refer to the 3 dimensions of universal health coverage and talking about sort of the percentage of people covered, the cost, or who covers the cost and what services are offered. I'd like to ask Dallas how the decision point is done between when you're deciding what package to offer. Do you go for let's cover the largest amount of people with a certain package, Or do you go about saying, no, let's start with the package, give the maximum we can, and see how many we can cover?
Thank you very much. I think the decision to, as of what package we offer, is pretty, the number one priority or concern of our leaders is, what have you done for the smallest who is suffering? To the extent that any minister, any high rank last night, and what he talked about the accent on the population. What we do here is death audits. Death audits, maternal death audits, child death audits are so centered in our system that we look in all the different stakeholders who defines. It's easy when we say, let's define a package that will be delivered to the beneficiaries or the affiliates. It's the primary health package. We reduce the number of people that will be served. That is a no-go for Rwanda. Then we say, let's see, we cover most of the people and see what's the package that we can afford. That's a better scenario for us because, first of all, we can't choose who will die and who will not die, who will suffer and who will be waiting until the benefit gets to them. So we chose to go with the entire population. We go with the entire population, and now we find innovative ways of delivering services. Vision for the Nation is one of them. We are bringing on board private or an international organization to support the delivery of some services. Of course, the key question will be, what's the sustainability? Remember, at first, the mindset of insurance is not something that everybody gets in the first go. A lot of our population, when they have not been sick the whole year, they assume that they can take chances for the following year. Then that will not allow you to run a successful insurance scheme, especially an informal sector insurance scheme. So what we need to do right now here, and what we have been doing in the last 12 years, is building the insurance uptake mindset in our population. It's also building the mindset of the health services providers. I liked a lot the panel that came before here. They talked about the use of medicine. They talked about the data that have been pulled out of the facilities or different health services. It's important to know that if we need to be as effective as we can so that we deliver as much care to the biggest part of our population, to the biggest number, we need to be as effective as possible. We need to go into generics. We need to make sure that those generics are of good quality so that they actually do the purpose for which they were prescribed. So we went for the most daring scenario of covering all the people with most of the services. But along the way, we are pulling in the different stakeholders to make sure that we are being effective at what we're doing. We are building the mindset both in our affiliates population and on the providers' daily practice. And going forward, even though we started with a very low premium for enrolling into the Mutuelle de Santé, it will be increasing. But then by that time, I'll have had the testimony of my child who had fever in the community late in the night, and I was helped by a community health worker who was able to give me an antipyretic because the insurance paid for the services she rendered, or the health facility, or the ambulance that took the mother to the hospital. So all of that are mindset changing achievement that will help us to be more focused on what we deliver, who we deliver it to, in order to improve it whenever it's necessary. Thank you.
Thank you, Doctor. And I'll have a question for Dr. Gitahi and also Dr. Abdallah, because you both outlined 3 factors, and they're quite similar: access or equity, quality, and financial protection. And as we know, what gets measured gets done. So I want to ask you, before I move to the audience, how do you measure these factors? So you've set them up front, saying this is what we should be looking at. How do you go about measuring them? It's a question for both. Perhaps we'll start with Dr. Gitahi and then Dr. Abdallah.
I think this is something you can answer in 2 ways. First is, if that question was asked to the panel, it would be a very scientific question in terms of how do you measure. WHO has standards, they have what, quality health indicators, and there are all these there, and many of them are part of the targets for SDG number 3 within that framework. For us, we tend to use that, but most importantly, also to have a social contract with the community and ask the community first to be participants in setting up the services that they require so that we know what their need is, and therefore we emphasize more for bottom-up kind of programming and bottom-up health systems like Rwanda has done. And within that social contract, the community will have to actually be part of the measure itself for the accountability mechanism. I like what is happening in Rwanda in terms of knowing exactly who died, when they died. The community knows these things. So even if you had very high-level data within the district health management information system, and a child dies and the family doesn't know why they died, your measure system has failed. Because there must be a social contract with the community to feed back to them. And when you engage the community in creating universal health coverage or universal healthcare systems, you must also be answerable to them on a day-to-day basis. So I want to move away from the statistics and just talk about that social contract. That if you are in a community and you provided a health center or district, a hospital, and a child dies, there is a responsibility of that hospital or whoever is in charge of that health themselves. Are we doing well? Are we not doing well? But of course, we can all get more interested and more kind of attracted towards global statistics and the national statistics of maternal mortality rate and all these things. At the end of the day, it's down to the community. Is the community feeling the coverage that is adequately?
What I can add is that when there is in place people-centered governance, it's not so complicated to measure because of accountability. So all those health providers and other people involved, they have to be accountable. Of course, also there is a need, or it's through the robust monitoring mechanisms in place. And then the combination of both can ensure that the equity and access are there. Thank you.
Yes, very quickly, I could add something. I give an example of this measure issue. I give an example of Rwanda. When I go to the Rwanda villages and all, when you talk to the population, you feel they say, yes, we have a good healthcare system. Now, when you go to a country like Kenya, where I come from, the government will give statistics and say, we've achieved this, we've provided free maternity care. But when you go to the community, they say, but when I go for free maternity care, I need money to buy gloves, I need money to do this and this. So the community is unhappy, but the statistics are good. That's a social contract I'm talking about, that the measure for success has to start at the bottom. Is the population happy with the provision of UHC? Then that should reflect on the national statistics and the regional statistics and the global statistics.
Thank you. So we're now going to move to the audience. And I just wanted to add a side comment. The insights you're seeing from the panel, from this panel, from previous panels, these are actual questions that your governments are having to answer, your organizations are having to think through. So I hope that you are writing down what your thoughts are and hopefully you're engaging others, because this is the right platform. You have people from across the world that are here. You know, talk to your neighbor, tell them, this is what I'm getting from this. What about you? So let's now move into the questions. Simple rules. We'll go with the name, what country you come from, and straight to the question. I mean, one line, if possible. Go ahead, sir. Gentleman on the side.
Yeah, thank you. My name is Solomon Oshawahewa. I'm a recent graduate of biomedical engineering from Makerere University. And biomedical engineering is about, our role is to provide you, the doctors, with medical equipment that you need to provide the care that is appropriate in the setting. So the challenge that I notice in this field of biomedical engineering, and my question is directed towards Dr. Sorry, I forget the name. The doctor from AMREF.
Gitahi.
Yes, Gitahi, sorry. So I want to know what AMREF is doing to ensure that the medical doctors in Africa or in sub-Saharan Africa have the medical technology, or utilize the medical technology that is available. Because you find that in the health facilities in Uganda, for example, and sub-Saharan Africa, have medical equipment brought in by donations from the international scene, and most of this equipment does not work. Actually, 50% of the equipment in these hospitals is down. So how are you, what are you doing to ensure that we utilize the equipment that we have? Even because we know, I think we all acknowledge the role of technology in medical, in healthcare service delivery. Because for example, the utilization of point of care diagnostic tests for HIV had a big role to play in achieving the first 90 of the USAID 1990. So what are you doing to ensure that they have the necessary tools such that they're not helpless to help the people that need help? Thank you.
Thank you. So we'll take 2 more questions and then we'll come to the panel. I want a lady. We are here for gender equity. Yes, in the front with an orange, right here. So you state your name, where you come from, and then the question and who you are asking the question to. Thank you.
Okay, thank you. My name is Marie-Sharon. My question can be answered by anyone in the panel. We know that healthcare is very expensive, especially for people with chronic conditions. So I would like to ask, how do you match the cost and the quality of healthcare, especially in the universal health coverage, considering people with chronic conditions? Thank you.
Thank you. So one more question towards that side. Yes, there's somebody that's almost standing, so if we can get him the microphone. And then we'll come back to the panel. We'll have time for more questions. Yeah.
Thank you. My name is Alix Arlonsou. I come from Benin. And I want to ask my question to Dr. Akiba. But first, I want to ask if I can go in French. OK, merci beaucoup. Je voudrais savoir si la population rwandaise doit faire une cotisation, je ne sais pas, sur une période donnée pour pouvoir bénéficier de l'assurance santé. Et aussi, j'aimerais mieux comprendre en quoi consiste le concept de mutuelle de santé. Merci.
Merci beaucoup. So perhaps we start with the general question about healthcare and chronic conditions, and we'll have each panelist answer it, and then we'll come to the question for AMREF and one for Dr. Hakiba. So the view towards healthcare cost quality in the context of chronic conditions.
Thank you very much. Marie-Jeanne asked about the cost of care and the key component of quality for NCDs. The way I think my answer is actually Dr. Abdallah sitting here with us is task shifting. I've lived in the US for studies, and my kids got sick, had to go to the emergency room for ear infection, no specific exams, got back with painkillers, and the bill was $800. I spent 2 hours there, was seen by a nurse. The doctor came like 5 to 10 minutes. On a student budget, that was cutting a lot of things. So when I hear your question, I see that experience, because I wonder, are we going to deliver the same kind of care here? Keeping it for a specialist and therefore increasing the costs for the insurance and for the co-payment? My answer is task shifting. There are some very simple tasks that can be shifted across the health system. So if today you can get your eyeglasses, you can have mental health consultation, you can have your teeth checked by a nurse that was properly trained and who knows what to deal with and what to refer, that will cut a lot on the cost of services you are receiving. If you can manage to bring antipyretics in the community, now the Ministry of Health is starting to bring palliative care into the community. So we need to see how the community acts as an actor in the service delivery and make sure that we together design strategies that will cut on the cost but will not compromise on the quality. It's important that in every initiative that we propose, we as all potential patients and all healthcare providers, we look into, we check ourselves for quality, but then we don't shy out to make sure that the smallest or the furthest person in our country is actually accessing care without the burden. Because remember, when you bring the case of, let's say, hypertension to be treated by a doctor, we have no doctor at the health post, we have no doctors at the health center, we bring them at the district hospital. We talked about cancer, stage 3 and 4. If they need to come, they'll come to Kigali. They go to Rwinkwavu, to Butaro. You are moving somebody who was already very vulnerable within his own community or her own community and taking him or her to Kigali. Now, to all the suffering and the disease and then the hopelessness, you're adding to be confused and to need to be oriented through the whole system. And not maybe getting the same, care that they thought they will get from their own community. So my answer would be task shifting and making sure that we can deal with most of the diseases at the very lowest stage of our health pyramid. Thank you very much.
I'll go, Dr. Gitai.
Okay, very quickly on this question, I entirely agree with what Dr. Akiba has said. So I'd just like to add one other bit to say that the cost of healthcare in US, because she's given an example, is $8,000 per person per year. That's the per capita expenditure. $8,000, and I think now it's about $9,000. Do they still provide universal healthcare? No. The cost of healthcare on average in Europe would be range between $3,000 and $5,000 per person per year. In Africa, put that at $110. 110 compared with 5,000 and 9,000. So we cannot follow the route of Europe and North America. So we have to find a different way out of this cycle. Because if we go that way, we will never afford it. So the simple question is unaffordable. So the only way to actually reduce the cost of chronic care is to build a strong primary healthcare system and create a prevention mechanism. That is the best way to do it. And the governments in Africa need to invest so much in prevention, because if they don't, then they'll have to face the burden of care that you're talking about. So for me, it's about all these things that Rwanda is doing, lifestyle. It's about what South Africa is doing. They recently introduced a tax on sugar, 20% tax on sugar, and they're discussing now ring-fencing that to preventing chronic diseases. It's about these things, and that is where the government needs to invest. Other than that, we'll have to wait, as I said earlier, and invest in tertiary and secondary care and wait for all the people to come, and then the entire healthcare system will bust. So reprioritize our funding for healthcare from secondary and tertiary and take it down to primary healthcare so that we avoid the coming catastrophe.
So I agree with my colleagues, but I can add that we need also to ensure the quality of teachings and trainings to make sure that they have what they are supposed to have so that they can deliver quality services, but at, again, primary level. Thank you.
Thank you. So perhaps a quick comment about biomedical engineering and the use of equipment and ensuring that it's being done properly.
Thank you for the question, because it's a really heavy and critical question, because as you said, significant number of equipment that we have in our health facilities, and you refer to about 50%, actually not in use. And this is because of, as you said, there is a lot of investments that are not bottom-up, they are not centered on the need of the community and the ability to provide care at that particular facility. So we have donors who will bring expensive equipment, and we receive them because they are donations. And we place them in hospitals, but there's no health worker skills or capacity to actually manage this equipment. The other thing is, I'll give an example of, and I keep giving Kenyan examples because it's very close here to Rwanda. And recently, we invested in what we call the managed equipment service. It was a brilliant project. We invested in ICU beds, C-arms, for those of you who understand C-arms in orthopedics, MRIs, and all these things. 1 year later, there's a crisis because a lot of this equipment, which were equitably distributed, there was no study to understand the gaps within the industry, to say which hospital requires an MRI, which one requires a CT scan, which one doesn't require any of this equipment, and we'll create a referral system for that. Because of the political drive, we invested in this equipment in 97 hospitals equally across the country. So you'd imagine what would happen now is because there was no accompanying human resources or skills, biomedical engineering, or even training, most of these now are idle a year later, and now we are rethinking how to redistribute them, so it's a waste of resources. So that's number one. Number two is responsive curriculums. We know that right now, a lot of the radiology equipment that are coming are using imaging. It's imaging coming up. But if you talk to any of your colleagues who are in medical training colleges now doing radiology, they still go to the dark room and they do exams on the dark room. And there's no training at all on digital imaging. So again, and I know the Vice Chancellor is here, there is need for us to talk to the training institutions to adapt their curriculums continuously so that when we provide equipment that are coming through research, and the researchers were here earlier, the medical professionals we are developing don't have to then go back for in-service training. They can actually, it can be done in pre-service if we anticipate the change that's happening. Finally, it's about active citizenship. We have people in our countries who walk to a hospital, the X-ray machine is broken down, they are told come next week, they come next week, it's broken down, they are told come next week, and our people are extremely humble. They never ask the question, why is it that I've come here 3 times and there is an X-ray machine here? Why is it? And I keep saying, and I said this in the WHO meeting last year here, and I was called an activist. Why is it they don't go to court and say, I've been here 3 times. The inconvenience is not worth it. So somebody has to hold the people accountable. You cannot have broken equipment and patients come and they're told come back and they're traveling 3 hours to come for an X-ray. Nobody bothers about it. So one of the things that we have to do to resolve this issue, and for us as AMREF Health Africa, is now within our strategy, is create active citizens, empower the communities, to hold their governments and their providers accountable, empower them to participate in planning, empower them to participate in budget making. The biggest thing we can do for African healthcare is create active citizenship.
Thank you. Il y avait une question sur la mutuelle de santé, la cotisation.
Merci beaucoup. Mademoiselle Alix a demandé, est-ce qu'on a une cotisation pour la mutuelle de santé? Oui, la cotisation est annuelle et elle dépend de la catégorie dans laquelle la personne se trouve, la catégorisation socio-économique qui s'appelle Ubudehe. C'est une approche typiquement rwandaise de catégoriser la population selon leur capacité ou leur capacité financière. Alors, il y a certains critères qui sont suivis et la communauté catégorise chacun des membres de cette communauté-là et ils payent la cotisation de façon annuelle et l'année de la mutuelle de santé va du 1er juillet de l'année, du 1er juillet au 30 juin de l'année suivante. Quand vous adhérez à la mutuelle de santé, que vous payez pour la première fois, vous attendez 30 jours avant de pouvoir accéder aux services de santé, juste pour éviter que les gens s'enrôlent dans la mutuelle étant des gens malades pour pouvoir juste bénéficier. Mais ça permet à ce que les gens se disent, si j'adhère à la mutuelle suffisamment tôt, j'ai 1 mois d'attente et après les 1 mois, je suis couvert tout au long de l'année, moi et ma famille, hein, parce que la cotisation, elle est individuelle, mais l'adhésion à la mutuelle de santé doit se faire par famille. Un individu ne peut pas accéder, ils sont enregistrés en ménage. Le concept de mutuelle de santé, c'est tout simplement le concept des assurances. Ça s'appelle mutuelle de santé ici, ça s'appelle assurance santé ailleurs. C'est vraiment, ici, la mutuelle de santé concerne le secteur informel, des gens qui n'ont pas de salaire à la fin du mois. Ça va du maçon à la maman qui vend des bananes au marché, à la personne qui est pensionnée, qui n'a plus de travail, par conséquent, il n'est plus affilié à une certaine assurance commerciale. Tous ceux qui n'ont pas d'assurance donnée par leur emploi adhèrent à la mutuelle de santé. Et je crois que le Dr Coutinho a dit tout à l'heure aussi que nous avons accepté, en collaboration avec le HCR, d'enrôler les réfugiés qui sont sur le territoire rwandais, parce que la loi dit que toute personne se trouvant sur le sol rwandais, au-delà de 30 jours, doit à tout prix être couvert par une assurance maladie. Je crois que les autres détails, ce serait peut-être long à expliquer. On pourrait prendre un temps à part pour discuter des différentes modalités. OK? Merci.
Thank you. So Dr. Hakiba was basically quickly reviewing the community-based health insurance. So I have a bad news and a good news. The bad news is we've run out of time. The good news is we have our panelists that are still here around. We have our keynote speech that will be here as well before he returns to the village. But we're now sort of closing down this plenary. And I'd like to ask each of the panelists for just a brief 1-2 minutes message to inspire us, challenge us as we think about this concept of universal health coverage and what each of us can do. We've heard about the factors, we've heard about what can work. We now want to, have a call to action for the audience. So perhaps we'll start with Dr. Hakiba.
Thank you very much. I think my remark will go to the students. I know that have been there, I know that when you look for a job, they keep asking you, what's your past experience? Which is a weird question. I have no past experience. I'm just fresh from school, duh. But you need that job, right? I think as much as we can learn from each other, I'd like to draw the example of some countries. Look at Europe. I'll just say Europe in general. Look at the US. They have internships. internship gives you the opportunity to match your theoretical learning your theoretical learning with the actual marketplace challenges, and makes you relevant. When you get at the point of writing your last year essay or memoir, you are right on point because you've had the ability or the opportunity to look into the existing issues in the sector you are studying. So let me challenge you and actually call you, at least those in Rwanda, to come and help us. When you deal with the payouts for, in health insurances, when you pay the services that were rendered to our affiliates, one of the key questions that come to our mind is, are we paying for the right things? I can't sit as a medical doctor and check all the prescriptions that were given to my affiliates. Yet, I need to know if generics are being prescribed or not. I need to get the feedback after treatment. Did this treatment, this prescription, help my affiliate and the patient of this doctor? So I think there's room for you to come in and say, let me take these 2 or 3 health facilities. As a pharmacist, a student in pharmacy, this is how, with the mentorship of your teachers, this is how you look at the accuracy or the proper prescription that our affiliates get. And you look at that facility, and by doing that, you help yourself, and guess what? You help me too. That makes 2 people happy. We can work on different ways to make your studies relevant early enough in your curriculum to make you marketable when you start looking for a job. If somebody comes to me today and say, we are putting this position on the market and we need like 2 or 3 pharmacists, and you come to me looking smart and say, I am freshly baked pharmacist from the university, my first point would be, I'll need to train him. Not a bad thing, but maybe you'll be delaying delivery. But if you come to me and say, while a student, I've conducted a research on this and that and that, I look at you in a different way. I know that this person will hit the ground running, and at least, you know, he knows what he's doing. He knows why he's in that field. So I would like to challenge you and challenge ourselves and challenge the academia. Can we get in touch and make things happen? Here in Rwanda, in Benin, in Uganda, in everywhere, this is possible. So that we know that people that are being produced by universities, all those great minds, there's no such a thing that a smart person who is not relevant in what they're doing. So the only way of being relevant is actually to come and see how you can bring your stone to the building. I think this is a task for me and for you, but make sure that all the universities, all the faculties have that component of really matching, and Dr. Gitahi said it, the active citizen, you know, find your place, force some doors, and you can only force them when we have the right argument, and then doctors to come to us. We'll come to you too. Thank you very much.
Thank you. First is to the Student Federations. I think there is a rapidly changing human resources for health area and mix of skills. And I see a lot of people have predetermined they're going to go into study. Things like biomedical engineering are required, things like radiography. We have a lot of requirements for anesthesia technicians and all this. But everyone wants to just become doctor this and that and that. I think it's good for you to lead, become an active organization, and start to lead within your members and within those who are in high school who are going to be our members, study and be able to advise them and tell them the professions of the future in the medical profession are the following. Because we are reaching a place where in some of the countries, we have doctors who are placed in the urban areas, and there are so many that they don't go to rural, and therefore you find a facility has succeeded because it's actually overstaffed as far as medical officers are concerned. And it's going to come to a time when our governments are going to say we are no longer going to automatically employ doctors because we have an oversupply. So recently, my daughter is in medical school. She's actually in second year in Kenya, going to third year. She gave me this thing that was heartbreaking. She told me she did her exam in second year in community health. And they had an exam on Millennium Development Goals, and they were told to recount which ones are they, what are their targets. Millennium Development Goals ended in 2015. We're now on SDGs. There was even no bridge over to SDGs. Our university curriculum is responding to the needs of the global health agenda and converting these people, as was called, a social movement. These students here can be part of this social movement of declaring health a human right and going to practice when they know these things that we are discussing here. UHC, health a human right, quality, access, financial protection, so that they're not just going to sit in a clinic and continuously celebrate success. And at this time, I'll do something very unusual. I want to ask for a standing ovation for the Rwanda healthcare system. As an advocate of universal health coverage in Africa, I know that what Rwanda has done is unprecedented across Africa, and we need to divest them.
What I can say briefly is that we need involvement of all stakeholders. All stakeholders need to be involved. Students, tomorrow, they will be part of the decision makers, so they need to be involved. So like now we are working with medical students in the outreach in the community. So I think that's a big thing because in future they are the ones who are going to take the lead. So to the university, I think the university needs to do a continuous review of curriculum to match it with the field situation. So, and finally, universal health coverage is a very powerful concept that public health needs to offer. Because for me, I look at it as a full and inclusive. So we need to ensure its quality, its efficient, the equity. And then universal health coverage is a journey, is not an ended goal. So, and therefore all countries must take actions to accelerate
and say that I humbly accepted that handshake on behalf of 9 to 10 million people of Rwanda. He couldn't shake the hand of all community health workers, all doctors, all nurses, all leaders, but seriously, it's a teamwork, and I can't see one person that can be attributed that success to unless it's our president that is actually putting all those blocks together. Thank you very much.
Thank you very much. So we come to the end of this plenary. So I hope you get many of the messages, many insights from whether it was the video from Sir Marmot about the social movement challenges, but there's hope, whether it's the message from many of our panelists, whether it's adding a stone to the building, each of us each of us in this room has that duty, whether it's to be an active citizen and for universities as institutions to help the students adapt and be ready, and for all stakeholders to be involved. And so we thank you very much.
Okay, wow. I think we are learning so much. I'm learning a lot. And I hope you guys are all seeing the links between the themes that have been covered so far. I mean, I wish we could take this for longer, but we are running out of time. So I'll do a quick recap in French for those who don't understand English very well. Les points sur lesquels on a discuté, ce qu'ils ont dit aujourd'hui, c'était surtout, dans la vidéo, ils ont dit que la justice sociale ne peut pas être séparée de la santé, donc on doit toujours, et ils marchent toujours ensemble. Et puis, dans les discussions qui sont passées, on a parlé de la santé, les problèmes de santé nous affectent globalement, ce n'est pas individuellement. Donc, si une personne est malade, ça nous affecte indirectement, mais c'est tout le monde qui est affecté. Et les besoins de la santé primaire devraient être prioritaires, surtout dans nos communautés ici en Afrique. Happy birthday, Bruce!
We've had a great team organize this summit, and we wouldn't be able to do it without some of the designers. So if anything designed from your booklets to the backdrops, it has really been his work, and we're really, really grateful for him.
He's right there behind. For those who want to
so can I give him a birthday shout out? Yeah.
Happy birthday.
So thank you, everyone. We'll see you the tea break is ready.
So, just to remind you, please, those who have
my great pleasure to welcome